Well, thanks for joining us for this special Education Day event. And today, which has really been recognized nationally as Interstitial Lung Disease Day. It's an absolute delight to have you all join us for this session. We'll have a short Q&A session at the end, so feel free to type in your questions as we go along with the presentations. And there will be a moderator who will be presenting the questions from the audience as well. I am Ayodeji Adegunsoye. I'm an assistant professor of medicine. I also serve as the scientific director for interstitial lung disease here at the University of Chicago. And I have the honor of being joined this lovely afternoon by my esteemed colleague, a rheumatologist extraordinaire, Dr. Folkman. Dr. Folkman?
Hi, I'm Elizabeth Folkman, and I'm a rheumatologist at UCLA in Los Angeles. And I direct our scleroderma program and co-direct our CTD-ILD program, and I'm very delighted to be here today with you.
Welcome. And so I have to read this disclosure. The presentation is made on behalf of Boehringer Ingelheim Pharmaceuticals. The company has provided financial support for this program. The presentation content has been reviewed for consistency with FDA guidelines.
So when we think about the autoimmune diseases, interstitial lung disease actually occurs across the spectrum of various autoimmune diseases. So in this figure here, you can see the individual autoimmune diseases and then the prevalence of ILD among these different diseases. And what's striking to me about this is that diseases like systemic sclerosis, mixed connective tissue disease, myositis, they have a fairly high proportion of patients who have this predisposition to ILD. But even patients with lupus, rheumatoid arthritis, and Sjogren's syndrome can get ILD. These percentages, though, can vary depending on how someone detected the ILD. And I'm wondering if you could shed light on, the difference between using CT versus PFT for detecting ILD in these patients.
Yeah, that's a great question. In terms of the practical significance, CT and PFTs may not really have an equivalent high index of diagnostic certainty for making that diagnosis of ILD. A lot of it depends on geographical location, so there's some bias into it as well. And as you will see along the lines of this talk, PFTs themselves may not be diagnostic of the disease itself. They may just show us a functional impairment, as opposed to CT that shows you the structural abnormality, the architectural distortion that characterizes ILD. So there's a lot that comes into play. The CT and PFTs do not have diagnostic equivalents, and then there's geographical variation in how we make that diagnosis as well.
So when we think about the pathogenesis, though, of ILD among these different autoimmune diseases, there are some common features regardless of whatever the underlying autoimmune disease is. And so we generally think that there's epithelial injury, and this could be from something in the environment, a virus. A lot of times we don't really know what triggers it, but the result of that is inflammation and the production of cytokines, chemokines. It stimulates the immune system to actually activate fibroblasts and transform them into myofibroblasts. And this is what lays down the collagen and leads to the fibrosis or the scarring, which is really the hallmark of interstitial lung diseases. And when we diagnose patients, we go through a comprehensive evaluation, and each step is very important. So as a rheumatologist, I believe strongly in getting autoimmune serologies, and we're going to talk more about that as the lecture goes on, but specific tests that can help pinpoint the underlying disease and may even give prognostic information. We get pulmonary function tests to evaluate the degree of restrictive physiology and also diagnose other things like COPD and asthma. We also get CT scans, and this can help us identify the pattern of fibrosis in the lungs. And then again, you want to look outside of the lungs, because oftentimes patients will have extrapulmonary manifestations that can help you decide, do they have lupus or do they have rheumatoid arthritis? And then again, the CT is essential. So I'm curious for you, when you get a high resolution chest CT, it identifies ILD, what is your next step in terms of evaluating that patient?
Yeah, so in terms of how practical we implement those abnormalities on CT scan, the question that comes to mind is it of functional consequence? Is it of clinical significance? What we are seeing there, does it really correlate with an impact on the patient's quality of life, ability to exercise, or life expectancy. And so we often follow up a CT that's abnormal with a pulmonary function test to assess the impairment in the lungs as well.
Right. Right. And then we have the case, and this happens, in my space a lot, where I'll be seeing a patient with an autoimmune disease. I'll get a HRCT to screen for ILD, and it may not be there, but that doesn't mean that I stop looking for it. I will regularly obtain PFTs in these patients, assess their symptoms, and if there's any suggestion that an ILD could have evolved in the interim, then it could prompt you to do another CT scan.
Certainly.
And then the lab workup, again, is essential. And there's a lot of different autoantibodies that can be helpful, again, in helping to pinpoint the underlying autoimmune disease. And these autoantibodies can also give you prognostic information. So here are some. So the ANA antibody is something that's positive in a lot of different autoimmune diseases. So it's highly prevalent in patients who have lupus, who have systemic sclerosis. About half of all patients with myositis will have a positive ANA, and then maybe about a quarter with rheumatoid arthritis will have an ANA. So it's not necessarily specific, but if it's present, and if it's present at a relatively high titer, it gives you some indication that an autoimmune disease could be in existence. And then you have the more specific autoantibodies, things like rheumatoid factor, CCP, being associated with rheumatoid arthritis, the SSA, SSB associated with Sjogren's syndrome. You have the anti-synthetase antibodies associated with myositis. U1RNP, anti-SCL70 can happen in scleroderma. So these are very important. And in your practice as a pulmonologist, do you actually test for these autoantibodies when you see patients with ILD?
Yeah, we do actually. So most of the time when patients come to us from a referral basis, the primary care physician has often obtained a screening ANA or screening rheumatoid factor, and those are often the first indicators that there might be an autoantibody process going on. But at the time we see these patients, we often get a more extensive panel because we know that the value of this lies not just in diagnostic certainty, but also sometimes can be of prognostic significance as well. So we often will get a more extended panel for our patients who come to us at baseline visit.
Great.
Yeah, and in addition, so we talked about PFTs earlier on as a marker of lung function impairment. So these pulmonary function tests can often help us identify the severity of the disease in patients who have interstitial lung disease. And so what I often tell patients is, look, focus on the last column because that is probably going to be of most value to you. What we're looking for are numbers that are less than 80 or more than 120. We all want to be perfect. 100% is perfect, but hardly ever do we get someone who's 100% all through. So we take a range, 80 to 120%. Less than 80 is too low, more than 120 is too high. You want to be just right in between those two numbers. As we can see from the screen, the FVC, or the forced vital capacity for this individual was 85%. So normal. The FEV1, the quantity that was exhaled in the first 1 second, was also 85%, again normal. The TLC, or the total lung capacity, was 99%. That's almost perfect, but it lies within the range of 80 to 120%. So again, it's deemed to be normal. So was the DLCO, the diffusing capacity, and the adjusted diffusing capacity as well. In patients with interstitial lung disease, they typically have a restrictive pattern where the FEV1 to FVC ratio may be normal or increased. We note that in patients with obstructive lung disease, that value is often lower than 70% or impaired. On the contrary, the FVC, the TLC, and the DLCO are not usually normal. They're typically less than 80% predicted, so they're impaired as well. I want to point out here an important factor. It's important to note that patients may come to us with normal pulmonary function tests. It doesn't necessarily mean they don't have the disease. Again, this was a PFT obtained in a patient who had symptoms, as we often do. When patients have symptoms, this should not be ignored or taken lightly, particularly in the context of an abnormal CT scan. And that really should be taken into context. Dr. Volkman, how often do you see patients who have normal PFTs in your practice with defined rheumatologic disease?
Yeah, it's a great question, and we see it not infrequently, especially if we're seeing someone with a new diagnosis of an autoimmune disease and they're really early in their disease course. when we get PFTs, sometimes they are within the normal range, but keep in mind that these normal reference ranges are really ranges based on the population. They're not based on the individual patient. So it's possible, you know, in some of the patients we see, they have an FVC % predicted of 85 when they come to us, but we don't know that maybe 2 years ago it was 110% predicted and that individual patient has had a decline. So I think that PFTs become really valuable when you start getting serial PFTs to look for trends. But that first one, I agree with you, you really have to interpret within the context of the whole patient, their symptoms, their CT, and their underlying autoimmune disease.
Spoken like a true pulmonologist. So when we're evaluating our patients who have abnormal PFTs or they have clinical symptoms or signs that are really concerning, it's often the case that we'll obtain an HRCT scan. Now, we want to take note of the dominant feature, or the dominant features as they may be, as well as their distribution within the lungs. Oftentimes, additional imaging clues might exist that might point to a specific underlying diagnosis. What you're seeing on the screen here are listed some of the common HRCT features that we see in those with ILD. And we'll look at some of these features in more detail in subsequent slides. It's important to note the location of the features, whether they are upper or lower zone predominant, whether they have a more central or peripheral distribution. Each of these can help us identify what underlying ILD might be at play, and also the prognostic pattern that we should expect for these individuals. Now let's dive into some of these HRCT features. You may have heard about reticulation. Now, this simply just means or refers to the thickening of the interlobular or the interlobar septa that occurs within the lung tissue itself. Now, these are simply linear opacities that resemble a mesh or a net on HRCT scans. When we see patients with reticulation, it often indicates the presence of ILD. In the middle panel on your screen, we are seeing a pattern that's often called bronchiectasis. What that simply means is an irreversible dilation of the airways, the bronchi in this instance, that results from damage surrounding the airways itself. Now, what does that mean? I said traction bronchiectasis. Traction refers to pull or stress, and the bronchiectasis refers to an abnormally outpouch or prominent airway within the lung tissue. So in this case, lung fibrosis causes traction, pulling open the airways, making it more prominent, as is often the case in those with fibrosis. And on the right-hand side of the screen is what we often refer to as honeycombing. Honeycombing here results from the deposition of dense collagen tissue or fibers that destroys the underlying alveolar pattern or structure that we typically see within the lungs itself. Now, these are typically rows of cysts that are stacked on one another, typically about 3 to 10 millimeters in cross-sectional diameter, but they can be as large as 2.5 centimeters. Now, this often is the end-stage form of fibrosis, the most severe form of fibrosis within the lungs. Now, any of these can occur in those with IPF, idiopathic pulmonary fibrosis, autoimmune-related forms of lung disease, such as rheumatoid arthritis, hypersensitivity pneumonitis from inhaled environmental antigens, or even exposure-related forms of interstitial lung disease like asbestosis. It can be found in these diverse forms of ILD. And there are other features that we often will see as well, not just the last 3 features of fibrosis. Patients may have ground glass opacities. These are areas of haziness that overlie the normal architecture of the lungs, but they seem more hazy than usual. And you can also see features of the airways and the underlying vasculature beyond this haziness I talked about. So when you have preservation of the underlying architecture, we refer to that as ground glass opacities. In the middle of your screen is consolidation, where the alveolar air spaces are filled with exudates, and that often makes it appear to look more solid. And on the right-hand side are nodules. Again, nodules are quite self-explanatory. These are well or poorly defined regions that are either rounded or irregular in their morphology, and they can measure up to 3 centimeters in cross-sectional diameter. How often do you see these features, Dr. Volkman, in your practice?
So I see them quite a lot. All these different features can happen in across the spectrum of autoimmune diseases. And one thing, I'll point out is that these individual findings can sometimes have different etiologies. So sometimes when we see ground glass opacity, it can be a sign of extra fluid in the lungs or aspiration. Sometimes when we see consolidation, it could be due to pneumonia, obviously nodules, we think of cancer. And so, sometimes what I see is that when patients get outside CT scans, just these are commented on, but without saying this patient has ILD. And I think especially for rheumatologists who may not be looking at the CT scan, they really need to be aware of these words, because these are like the buzzwords that you need to know to then have a further evaluation for ILD. So I just think that it really has to, again, be interpreted in the context of the patient and what's going on for them.
Exactly. Very well said. We also see patterns such as what is called the non-specific interstitial pneumonia pattern, which unfortunately is quite specific. When we see this pattern in patients, we often think about some underlying autoimmune disease or some inflammatory process that has resulted in the pattern we are seeing in these individuals. The distribution can vary. It's very commonly seen to be subpleural, but it could be quite diffuse throughout the lung tissue. And in certain instances, they tend to have subpleural sparing, where the region immediately subjacent to the chest wall appears to be completely uninvolved as opposed to the rest of the lung tissue. When we see these features, again, we should be thinking about some interstitial lung disease that may be autoimmune related or another cause of ongoing inflammatory process within the lungs. The features on CT scan that might suggest this NSIP pattern are what we referred to earlier. They could be ground glass opacities. You could find features of fibrosis, such as the traction bronchiectasis and reticulation we talked about before, and they may be quite homogeneous throughout the lung tissue itself. Again, when we see this, a high index of suspicion for autoimmune lung disease, as well as exposure-related forms of disease, should be entertained within the individual. And then the usual interstitial pneumonia pattern, which is what we usually used to see in those with IPF, arguably the most common form of ILD there is till date. Now, this UIP pattern follows a typical distribution. It's said to be classically distributed in a peripheral subpleural fashion, basally predominant, and spares the upper lobe until much later progress of disease has involved the upper lobes. And so when you see this pattern, we think about a usual interstitial pneumonia pattern. The features are, again, features of fibrosis. They have honeycombing, they have traction bronchiectasis, they have reticulation. But when these are distributed in the pattern above, we call that a usual interstitial pneumonia pattern. What I often tell people is, think about pouring water into a glass. It fills from the bottom up, right? And that's typically the pattern in which UIP occurs. Or when thinking about the honeycombs, think about bees marching up from the floor up the sides of a wall, leaving honeycombs in their wake. That's exactly what you see. Honeycomb that's basally predominant and then subpleurally and peripherally distributed as you go from the bottom up. And so when we think about patients who have interstitial lung disease, it's important to identify whether they're progressing or not. And markers of progression can include features on the HRCT that we just talked about. So increase in fibrosis, in the distribution, in the morphological pattern. If they're more symptomatic, if they have an increased burden of cough or shortness of breath, if their ability to exercise or walk long distances becomes progressively impaired. When patients are identified as having more burden of disease by their clinicians, or even they have this subjective impression that they seem to be worse, those should be taken very seriously. And eventually, patients may often get full pulmonary function tests that tell us that DLCO, that's the diffusing capacity, or the FVC, the forced vital capacity, has declined from their last performance of this test. All of this should be taken very seriously and addressed accordingly.
So now we're going to transition to talking about some cases that will help illustrate lung disease in patients with autoimmune disease. So the first case is a patient with rheumatoid arthritis-related ILD, and it's an 83-year-old man whose chief complaint was shortness of breath. His past medical history was notable for osteoarthritis with chondrocalcinosis, osteopenia, bladder cancer, as well as BPH. And in terms of his exposure history, he had a 10-pack year smoking history. He quit at the age of 26 and had no other exposures like to birds or occupationally. Right away, there's already a few features here that make me think this patient could be at risk for ILD. Number one, he's a male, and there's a higher prevalence of ILD in males with RA. He's older age, and then he has this smoking history.
So I'll ask you, I'll just take a pause and ask you, Dr. Volkman, your thoughts about the fact that he did have a smoking history in his past. Arguably, this was about 6 decades ago. Would you still countenance that in the context of his autoimmune disease?
I still would. I mean, I know it was a very remote history, but it's possible that it could be contributory. And also, we know with smoking, there's a higher rate of RA in general in these patients. So I think it could be related. I wouldn't worry as much in this patient about something like COPD, but I think it possibly could still be related.
That's very interesting. I agree completely.
Good. So in terms of the inflammatory polyarthritis, when this patient was diagnosed, he was 81 years old. He had elevated inflammatory markers. ESR and CRP were both elevated. He also had a positive rheumatoid factor and a positive CCP. And the CCP specifically is very specific for rheumatoid arthritis. And also both of these, when present, again, portend a higher risk for getting ILD when you have RA. He was treated with low-dose steroids as well as TNF inhibitors, but 2 years after the onset of RA, he developed a cough and shortness of breath. And he was diagnosed by his PCP with pneumonia. And this is something that I'm sure you commonly hear in patients that come to you, that in the preceding year, they had multiple bouts of pneumonia where they got antibiotics and sometimes steroids, and they would get better initially, and then their symptoms would recur. Is this common for you as well?
Unfortunately, it's an all too common recurrent pattern in my practice. Patients who've been tried with different antibiotics over months and even sometimes years before eventually recognizing that there is likely another problem that's not a pneumonia. And so I think you're right. A high index of suspicion for something else at play should be paid in situations like this. I was going to also point out that when patients come like this, you also wonder what else might be going on beyond the pneumonia. He's been on TNF inhibitors. He's been on low-dose corticosteroids. He has rheumatoid arthritis. And so having a broad repertoire of possible diagnostic entities that could be responsible for this, I think, is really important in such an individual. Yeah,
very good. So in terms of his medications, we talked about the steroids, the TNF inhibitor. He's also on a bisphosphonate. And then in terms of his physical exam, his vital signs were normal. He was SATI, normally on room air. He had Heberden's and Bouchard's nodes, which are just findings of osteoarthritis of the hands, but no active synovitis. So his inflammatory arthritis was controlled. But he did have bibasilar inspiratory crackles. And usually, and I'm not sure if you would agree, when we can actually hear it, usually it's definitely present.
Yeah, crackles, I think, portend poor prognosis in many instances. And when we hear that, we often think about heart failure, about pneumonia. But the fact remains, when someone has crackles, you want to get to the bottom of it. Why do they have crackles? And understand the reason for it, because it could be of prognostic significance.
Absolutely.
And so, as will be expected, this individual got PFTs. He got pulmonary function tests. And what do we see? Well, the FVC in him was 85%. The FEV1 was 85% as well. So both of them, as you can see, were within the normal range. There wasn't any overt evidence of significant obstructive lung disease. His FEV1 to FVC ratio was not really impaired. And what we see is his total lung capacity was also normal at 99% predicted. His diffusion capacity was similarly normal, both on the DLCO and the adjusted DLCO as well. Obviously, he got CAT scans. I got an HRCT CAT scan to further define what was going on. Remember, he had other symptoms and exposures in the past as well. His HRCT that was obtained showed findings that were consistent with a UIP pattern, a usual interstitial pneumonia pattern. He had a peripheral and basilar distribution of reticulation. He had some traction bronchiectasis, which you can see on the right-hand panel more clearly. And there was an evidence of early honeycombing as well. You might see these rows of cysts defined at the most basilar aspects of the lungs, in the posterior basal segments of his lower lobes as well.
So in terms of the interval history, 18 months later, he's having worsening dyspnea and productive cough, no improvement with oral antibiotics, but slight improvement when he increased his steroids, no signs of infection like fevers, chills, night sweats, or hemoptysis. but he has lost weight, and that to me is concerning. And there's been some recent research demonstrating that actually weight loss in the setting of ILD is actually a risk factor for mortality. In your clinic, when you start to see patients losing weight, what are some of the things you think about?
Yeah, I think unintentional weight loss is always a bad thing, and ILD is no exception at all. But you're right, there has been a lot of data that shows that weight loss, lower BMI, portends poor prognosis in ILD. When patients come to me in the clinic with weight loss, I begin to wonder, is there a defect at the level of the tissue, specifically tissue hypoxia, which might reflect the severity of the underlying ILD? Or is there some other process like a malignancy that might be driving this weight loss as well? The point at which a patient comes in with weight loss, we are obligated to drive down to the root of the cause of that weight loss, identify with more definite and more objective assessments or tests or investigations until we can find a cause for it. In the instance when we don't, we advocate for optimal nutrition and dietary recommendations that could help to surmount this challenge of weight loss that the patient is experiencing. And so in this individual, we obtained repeat PFTs as we are wont to normally do. As you can see here, the PFTs showed a distinct difference from what we saw before. His FVC had declined to 73%. The TLC, the total lung capacity, was now down from 99% to 78%. And the DLC, or the diffusion capacity, had fallen in accordance from 100% to 65%. Obviously, something is going on for this individual. This led to a repeat HRCT scan, which showed progression of his UIP and progression of his RA-ILD as well. What we can see here on the left-hand panel is that he had some evidence of airspace consolidation that might suggest what we call organized pneumonia. In the middle of it, we notice that he's got a new cavitary nodule. And in a patient who's immunocompromised, who has a past history of bladder cancer, who's had weight loss of about 8 pounds, obviously we're going to worry about this, and it raises the concern for, is this infection or is this malignancy? And so he got a CT-guided biopsy, and an aspiration of this nodule was performed. It was negative for malignant cells, negative on staining, and the cultures for bacteria, fungi, and mycobacteria all turned out to be negative as well. In fact, it was consistent with a necrobiotic rheumatoid nodule. Is this common in your practice, Dr. Boukman?
Absolutely, and I think this case nicely demonstrates the myriad of radiographic findings you can have in RA-ILD, where it's not always just UIP. You can have consolidation, you can have nodules, and sometimes these occur at different time points in the disease too. So just because, like in this case, someone starts out with UIP doesn't mean that they can develop these other features down the line too.
Interesting.
So to summarize, pulmonary complications of RA can involve not only the parenchyma like we've seen here, but they can also involve the pleura. So patients can get pleural effusion. Sometimes they're pretty significant. It can involve the airways, including bronchiectasis. And among these different pulmonary complications, ILD is the most common. And we think that it occurs in about 10% of RA patients, but it actually may be there and at least 30% subclinically, meaning that it's there, but we haven't even detected it yet. And usually we see a restrictive pattern on the PFTs, and the UIP pattern is the most common pattern we see radiographically. We talked about some of the risk factors, so male sex, older age, smoking history, seropositivity, but then also genetics is something that again is emerging, and the MUC5B promoter variant has been associated with an increased risk of ILD in patients with RA. Survival is worse in these patients, so this is why it's really important to diagnose them early with ILD. The 5-year survival rate is estimated to be only about 60%, which is, much less than what you'd expect for RA without ILD. And so, if you have suspicion, I think the PFTs and CT are important. What do you tell your rheumatology colleagues, let's say, who have a practice where they see rheumatoid arthritis patients? How would you advise them about when to get a PFT or when to get a CT scan?
Yeah, so I think there aren't any strict guidelines about when to perform CT scans, but we should have a very high index of suspicion. As you rightly pointed out moments ago, about 1 in 3 patients with RA will have subclinical ILD. At what point does that change from subclinical to become overtly clinical, right? Can we get ahead of this lead time bias? Can we recognize the symptoms earlier? Should we be advising patients who are found to have abnormalities on CAT scan to avoid vapors, gases, dust, fumes, infections, things that can inherently worsen their underlying lung disease? And so those might actually argue for more, overt screening measures in these individuals. But I think overall, a high index of suspicion should be paid to patients like this.
Totally agree. All right, so let's move on to the next case. This is systemic sclerosis related ILD. This was a 48-year-old male surgical assistant. 6 months ago, he developed bilateral carpal tunnel syndrome and then had a carpal tunnel release. And about a month after that, developed puffy hands and was referred to rheumatology. And when you see this term puffy hands, it's actually a very specific thing. It's when the skin of the hands becomes swollen. So it's not necessarily swelling in the joints, it's swelling in the skin. And usually these patients have involvement of their entire hand. So not only the palm, but the fingers too. On review of systems, he reported Raynaud phenomenon, GERD, as well as arthritis in both hands. And in terms of his serologies, he had a moderately positive ANA at 1 to 640 with a nucleolar pattern, but he was negative for some of the other scleroderma-specific antibodies like SCL70, centromere RNA polymerase 3, and then they also checked rheumatoid factor CCP, probably because of his hand complaints, and those were both negative. So this patient actually has a lot of features of systemic sclerosis right here. And then he was actually, though, diagnosed with undifferentiated connective tissue disease, and this is not uncommon, particularly when the patient doesn't have the scleroderma-specific autoantibodies. There are some, practitioners who would say, oh, there's no scleroderma, but if you look back at his history, he has a lot of features of scleroderma, the puffy hands, the Raynauds, the positive ANA, and actually studies have demonstrated that with those 3 features alone, you have a pretty high chance, upward of 75%, of getting scleroderma in the next 5 years. So the patient, though, was treated with steroids, immunosuppressive, and antimalarial, but then about 8 months later started to develop dyspnea walking from the parking lot to the hospital. And then on that follow-up, they investigated further. So he was a never smoker, no exposures. He had mild sclerodactyly, which just means thickening of the skin of the fingers. And his skin score MRSS was 2, so he got 1 point for each set of fingers. He had bibasilar inspiratory crackles, and then on his Neofold capillaroscopy, he had dilated capillary loops with dropout. And this is a pattern that we often see in patients with scleroderma. So he was diagnosed with systemic sclerosis, and there was a concern for ILD.
So we have a gentleman, a middle-aged man with initial symptoms at baseline presentation who now has progressively worsening symptoms. Obviously, we're going to find out what's going on with the lungs, get a PFT. His pulmonary function tests showed significant diminution. As you can see, he had a reduced forced vital capacity to 56% predicted. Remember, this value should be between 80 and 120. This was really diminished. There weren't any apparent obstructive airway disease, as you can see from his FEV1 to FVC ratio of 85%, but his diffusion capacity was decreased to 60% predicted. And this restrictive pattern that we're seeing was consistent with his scleroderma ILD. Obviously, he got a CAT scan to further delineate what might be going on in the lungs. And when we looked at the CT, as you can see on the images, he had ground glass opacification, some reticulation, particularly at the periphery around the margins, and in the basilar segments as well. And you can see also that he had already developed some traction bronchiectasis. The airways on the right-hand side panel seem to be stretched out, pulled apart, traction bronchiectasis. Now, this pattern is certainly consistent with what we call an NSIP pattern, or a non-specific interstitial pneumonitis pattern.
So in terms of the management, I think it's helpful to keep in mind that ILD is the leading cause of death in patients with systemic sclerosis. So in some studies, it accounts for up to 35 to 40% of deaths. And there are risk factors. So patients with scleroderma who are male, African American, have older age, have more diffuse skin disease, or have these specific autoantibodies, these patients are more likely to get ILD. But this doesn't mean that females can't get it, that non-African Americans, that patients with limited skin disease. These are just risk factors that portend a higher likelihood. We recommend screening all patients with a CT and PFTs, and this is largely for the reasons that we talked about earlier, where sometimes early on in ILD, the PFTs can be normal. So if you really want to detect early interstitial lung disease and identify patients at an earlier stage, you have to do the CT. And the multidisciplinary discussion I find to be just essential for establishing the diagnosis, coming up with treatment plans. And I'm curious where you practice how you do this multidisciplinary discussion when you see a patient like this.
Yeah, so a patient like this is a little bit different from the last one we talked about, right? This is systemic sclerosis, where there are predefined objective risk factors for progression, for mortality, for hospitalization as well. And so such patients, we come together as a group, like we do in all our ILD cases, and have a multidisciplinary discussion between the primary care physician when it's available, the pulmonologist, the pathologist, thoracic radiologist, rheumatologist, to help ascertain the veracity of the diagnosis, because that's how we can begin to define what therapeutic interventions should be at play in this individual. Our MDD sessions typically hold weekly. Now, it may not be feasible for every center to have weekly MDD sessions, but we typically have ours every Tuesday afternoon, where we discuss patients like this to ascertain the diagnosis and work out a management plan as a group together.
That's great. So now we'll move on to the final case, and this is idiopathic inflammatory myositis associated ILD. So a 60-year-old female referred to rheumatology by her pulmonologist with a past medical history of hypertension, diabetes, obesity, and obstructive sleep apnea. In terms of exposure, she was a never smoker, but she worked for 15 years in a textile mill where she was exposed to cotton dust. So 3 years prior to the rheumatology referral, she developed dyspnea and cough. And again, similar to that other patient, multiple hospitalizations for presumed pneumonia with hypoxemia. Each time she would get better with high dose steroids, but then as soon as the steroids were tapered, she would start to worsen. Her PFTs revealed severe restrictive lung disease. Her CT was consistent with ILD, and she was noted to have an ANA and referred to rheumatology.
You can see the marked reduction in her forced vital capacity to 52% predicted. There wasn't any evidence of significant obstructive airways disease, but the total lung capacity was also markedly reduced, as was the diffusion capacity as well. When you correct the diffusion capacity for the alveolar volume, it turned out to be normal, which is 121. And so again, in this case, there wasn't any overt evidence of concomitant pulmonary vascular disease, despite the severe restriction that she had in her PFTs. Obviously, she got CAT scan done, and the HRCT that was done showed marked fibrotic changes, aligning with the history we heard, with the PFTs we just saw. She had changes with reticulation, she had traction bronchiectasis, she had features that were really suggestive of a severe interstitial lung disease underlining this. Do you see this often, Dr. Volkman?
Yeah, absolutely. And you know, what's unfortunate about this patient and what we see is that clearly this patient had multiple hospitalizations for the same thing. And when you see a patient who's getting better with steroids, usually a lot of people feel better when they get steroids, but as the steroids are taper, if they start to feel worse, then we really think about an underlying autoimmune disease, because if that patient isn't on a steroid-sparing agent, as soon as you lower the steroids, the inflammation is going to come back again.
Right.
So in terms of the rheumatology evaluation, on review of systems, the patient had a facial rash, also reported generalized weakness and fatigue, and her activities of daily living were largely limited by her dyspnea. On physical exam, she had what appeared to be a hyperpigmented malar rash. She had periungual erythema with cuticular overgrowth. She did have normal proximal and distal muscle strength, but keep in mind she was on prednisone at the time. And in terms of her lab test, she had a mild elevation in her CK and aldolase, which are two muscle enzymes. She had a positive ANA at 160 with a speckled pattern, and a positive Jo-1 antibody, which is a myositis-specific antibody, but negative RF, CCP, double-stranded DNA Smith, as well as normal complement. So, to summarize this case, I think it's important to note that, oftentimes patients can have a pre-existing autoimmune disease and then be diagnosed with ILD. But ILD can sometimes precede the onset of an autoimmune disease, and this can happen in myositis months and sometimes years before the diagnosis of myositis is made. Who gets ILD, who has myositis? Well, we think that there's a risk that depends on the autoantibody profile for the patient. So for example, if you have an anti-synthetase antibody like the JO1, there's a much higher risk for having ILD. Even the less common anti-synthetase antibodies, when we see them like PL7, PL12, we also worry about ILD in these patients. And then finally, another one that's really important to measure is this MDA5. This is an autoantibody that's associated often with a very severely progressive phenotype, and we often, I'm sure you would agree, have to intervene very aggressively in these patients. In terms of the PFTs, we see a restrictive pattern, and on the CT, again, there's a myriad of findings. NSIP is the most common, but you can also see organizing pneumonia or UIP, and sometimes a mixture of all of these processes. And once again, the multidisciplinary discussion is really essential.
So the last three cases really demonstrate the heterogeneity in the presentation of ILD, where an autoimmune disease actually is underlying cause of the ILD. And it's important to pay attention to not just clinical features, but also serologies, the HRCT pattern, as well as the lung function test and how that might be impaired. But that being said, there is a really important part that impacts patient care as well. And this is the misdiagnosis that often occurs in patients with ILD. What I've depicted on the screen here is a survey that was performed recently amongst patients with ILD. And in this survey, over half of patients, 55% of respondents, had at least one misdiagnosis, while over a third had two or more misdiagnoses before the eventual ILD diagnosis was made. The majority of them, about 3/4 of them, had consulted 3 or more physicians prior to the actual diagnosis. And about 34% of them had a delay of 2 or more years before that diagnosis was made. And so it's important that we pay attention to how best to optimize the accuracy of diagnosis by recognizing the symptoms where present or additional features like laboratory tests, HRCT patterns that might indicate a diagnosis of ILD and hopefully subvert that delay in diagnosis that we're talking about here.
Yeah, and I would say that even in patients with any autoimmune disease, there's often a large delay in diagnosis where these patients kind of go from doctor to doctor. And because autoimmune diseases often disproportionately affect young women, these patients on the outside may look actually pretty well. And so they're sometimes told, oh, your shortness of breath is because you're out of shape, or you just might be overstressed. And so I really think it's important as providers that we listen to our patients very closely. And this next slide that you're showing, I think, is very interesting. This was a study looking at what was the first diagnostic test that was performed. And this was in a large group of patients with IPF identified through a Medicare database. And what you can see here is that something like the CT scan of the chest was not ordered the majority of the time, which is contrary to what you'd hope for. And I'm curious, is this what you see in your practice as well in patients, let's say, that are being referred to you by an outside pulmonologist or primary care provider?
Yeah, so that's a very interesting point, because in practice, the rate at which CT scans are ordered often depends on a variety of factors. Depends on geographical location, depends on practice provider patterns, depends on access to healthcare insurance. So all of those factors play a big role in who gets a CT or who does not. But ultimately, the recommendations still are the same. You really make that diagnosis of interstitial lung disease on a CT scan. And so you really want to get that CT performed early when that suspicion of interstitial lung disease is present, because that can ultimately impact prognosis, quality of life, and response to therapy.
So to summarize, the lung is frequently targeted in autoimmune diseases like Sjogren's syndrome, rheumatoid arthritis, systemic lupus erythematosus, systemic sclerosis, myositis, mixed connective tissue disease, and anti-synthetase syndrome. ILDs associated with autoimmune disease will often exhibit an antibody signature, which can be helpful in evaluating and monitoring patients. And the distribution of HRCT imaging features such as honeycombing, ground glass opacity, traction bronchiectasis, and reticulation can help point to specific diagnostic patterns.
Absolutely, very well said. So we've been talking about diagnosis of ILD, of autoimmunity in ILD, of ILD induced autoimmune diseases, and how there's a ton of overlap. How can we improve the certainty? How can we increase the accuracy of that diagnosis? Well, the current recommendation is for multidisciplinary discussions to occur when patients are being cared for by experts. Putting together the minds of experts who care for these patients can help finesse or refine that diagnostic certainty to come up with a diagnostic plan and a therapeutic plan for that patient as well. And so the MDD team often consists of the pulmonologist, the radiologist, and the pathologist, but increasingly the critical importance of the rheumatologist has been played up in the last several years to helping to refine this diagnostic certainty and coming up with an appropriate plan for management. When the primary care provider is available, they should be present at these discussions, and the respiratory therapists and the palliative care specialists as well also play an important role in helping to guide approach to therapy for patients with interstitial lung disease. All of these have been shown to impact mortality and prognosis, which obviously is of importance to the patients, but also to the care providers as well.
Yeah, and you know, you and I both practice at academic centers where we're fortunate to have these meetings once a week with all these people present. But I will say, I think there's an ability to do an MDD even if you're not in the same place at the same time. We're all a lot better now at connecting virtually as we are today. And so I would just encourage people in the community that have their own practices that you can still simulate this virtually, either with a phone call or getting on a Zoom with another specialist. Even our MDD, we allow other people from the community to join in if they have cases they want to present. So I think this can really be expanded and helpful for every provider, not just people that are at academic centers.
Yeah, that's an insightful perspective that cannot be overemphasized, right? In the recent era of the COVID pandemic, we've seen an increased reliance and increased leverage of telehealth facilities, of telecommunication resources, of virtual health measures being implemented for patients who are in those rural or difficult to reach areas or communities. And so more virtual meetings, more telehealth conferences have really been able to get clinicians or care providers to connect with tertiary centers where these MDDs are much more available, and that can also help impact patient care positively. So very great point. So while we've spoken quite a bit in the last hour or so, you can certainly get a lot more information from the sites listed on your screen. Just point your phone to the QR codes. You'll get more information on radiology rounds, on insights in ILD, as well as the RAD Rounds app to help provide additional information for details on what we just talked about. Thank you so very much for your attention, and we'll take questions at this time.
Thank you so much, Dr. Adekinsoye and Dr. Volkman, for that informative presentation. There are a couple of questions from the audience. First question I have, does the disease course of ILD differ depending on the underlying connective tissue disease?
Yes, most definitely. Even within individual connective tissue diseases, the progression of the disease can vary. So as an example, a disease like systemic sclerosis, we do see some patients who have this rapid decline in their lung function, radiographic progression that happens sometimes over the course of even 1 to 2 years. And then we have other patients where they have a more slowly progressive phenotype. They may progress at a different rate. So this holds true for all the autoimmune diseases. Everyone progresses at a different rate. And what's really important is to understand the risk factors for progression in that disease state, and then to be monitoring the patients closely. I would say one other point to that I think is essential to understand is for some of these diseases like systemic sclerosis, it was historically thought that, okay, once you got to 5 years, you are not likely to have any further progression of your lung disease. And that's actually not true. We see a lot of patients that have later gradual progression of the disease. So there's really no point in time in the disease where if a patient has ILD, you should stop monitoring them for progression. Would you agree with that too about monitoring?
Absolutely. So there's an increased recognition that about a quarter to a third of all patients with autoimmune diseases will have a progressive phenotype. And so while we know that, we also want to pay attention to other factors that might also accentuate that slope, that rapidity of progression. And things like comorbid disorders seem to be more prevalent in certain autoimmune diseases compared to others. So case in point, scleroderma, patients will often have pulmonary hypertension. They may have acid reflux or gastroesophageal reflux disease. All of these could contribute to the progression of severity of disease that these patients have. And so it often will depend on the underlying autoimmune disease, and we should pay attention to those as well.
Thank you for that. I have another question. What is the role of serology, if any, in monitoring disease progression and prognosis?
I can start again. So the serologies are helpful. We talked about they can point to a specific disease, but we also use them prognostically. There are certain autoantibodies that we know portend a higher risk of developing progressive pulmonary fibrosis. So we'll use scleroderma again as an example, but things like the SCL70 antibody, U1-RNP, U3-RNP, THTO, these antibodies, when they're present, portend a worse prognosis in terms of the patient's ILD. And all this means is that you're going to follow them more closely. You may treat them more aggressively. We have other autoantibodies in scleroderma, like the centromere antibody, that again are usually associated with a less progressive ILD phenotype. But I will say I've had patients with severe ILD with the centromere antibody that we actually even take to transplant. So I think that you use these antibodies to give you information, but just keep in mind too that every patient is very unique.
Yeah, I completely agree. I want to point to your earlier allusion during the course of the talk where you presented during the case that the gentleman with scleroderma had a negative scleroderma antibody, SCL70 was negative. But
right.
When we find that positive antibody, it often increases the risk. And so we want to pay attention to autoantibodies in patients regardless of the autoimmune disease or the underlying CTD. In our practice also, the MDA5 antibody is actually quite specific for prognosis. It has been known to confer a poor prognostic outcome in patients, and it can be a marker for determining who goes to lung transplant or not. And so there is increasing utility of these autoantibodies regardless of the underlying autoimmune disease.
Thank you. One last question. Do you have any advice for PCPs to better recognize patients that first present with possible ILD symptoms? And when should you order a chest CT?
So that's a great point. I can chime in on this. I feel like there is a significant under-recognition out there in the community of what constitutes significant ILD. And oftentimes on our lung cancer screening CT scans, patients are often identified by the radiologist as having ILD, but the terms are not highlighted or put in bold at a summary at the bottom of the results. And so when PCPs or clinicians see the results at the bottom, they often take those to heart without reading the entire context of, the 4 or 5 paragraphs of the report, where somewhere they've referred to fibrosis or referred to traction bronchiectasis or honeycombing. When these markers are found, there should be an immediate attention paid to those features and a referral prompted to a pulmonologist to cut down that diagnostic delay. That hopefully will reduce the detrimental outcomes that we have seen that are linked to the delay in diagnosis. And so recognition of features of fibrosis on the CT scan is one. Features of crackles, which we often hear in heart failure or in those in aspiration, should not be ignored. In fact, it is commonly said that someone who has crackles, who has a 3 percentage point desaturation on a 6-minute walk test, warrants getting an HRCT looking for ILD. Crackles are so very common, and we often attribute them to other things, right? But the fact remains that if you miss the diagnosis at the first point of contact, you might actually have to get 3 more clinicians before that right diagnosis is made. And so paying attention early on does our patients a world of good.
Yeah, and I would say with symptoms, it's sometimes hard to assess symptoms in patients, particularly with autoimmune disease, because if you simply ask them, are you short of breath? There could be a lot of different reasons why they may get short of breath with exercise. You know, maybe they've become deconditioned because their inflammatory arthritis or their myositis is not well controlled. It could also be that they say, no, I'm not short of breath, but then you discover through speaking with their partner or caregiver that they're not really exercising anymore. They're more sedentary. And so I think if you were going to see a patient in a primary care setting, if you have your intake form asking about shortness of breath, you want to, when you see the patient, probe a little bit further and really ask about activities, because again, people will modify their lifestyle to avoid this feeling, this very uncomfortable feeling of breathlessness. And sometimes that's not always captured on the forms that we give our patients when we see them, especially as a rheumatologist.
Absolutely. I'll also highlight that, like the case we just talked about, not all cough is pneumonia, not all cough is COPD, not all cough is heart failure. And so when patients come in with a cough that seems not to be going away, you probably want to get a CT scan to better identify what is going on. Because again, time is of the essence in our patients. Well, once again, thank you all for joining us for this educational event on this lovely September afternoon in recognition of Interstitial Lung Disease Day. We appreciate your presence with us and the questions that you have asked as well. Dr. Volkman and I will wish the rest of you a lovely rest of your day. Thanks again.
Thank you.